At the outset, let me thank Dr. Durusha Madam and team for inviting me for this talk on inositols in PCOS. So this was me when I got the invitation from the conference and when I got to know about the topic on which I would be speaking, that is inositols. After reviewing the literature, I got to know that there are 9 isomers of inositols, of which only 2 are deciphered, and of the 2 which are deciphered, this is the stern reality, more than 150 publications. So here we are at the crossroads, trying to understand how to deal with inositols in the perspective of PCOS. So as we all know, PCOS is a complex, heterogeneous, multifactorial disorder which affects the lady physically, mentally, psychologically, as well as hormonally. And Rotterdam criteria helps us to diagnose the PCOS, as it should include either 2 out of 3, either clinical or biochemical hyperandrogenism, oligoanovulation or anovulation, and polycystic ovarian morphology on sonography. So basically, looking at the multifactorial pathology associated with PCOS like anovulation, hyperandrogenemia, and insulin resistance, have we progressed from our age-old treasure of metformin to anything new? So today we shall discuss insulin resistance and hyperandrogenemia, metformin, is it the lost hero? Inositols, from physiology to rational therapy, malmilitol and dechiroinositol combination, is it a way out now? And what is the latest evidence on the right dose of inositol isomers? So if we look at the pathophysiology of PCOS, we know that insulin resistance is the main culprit, which results in hyperinsulinemia, theca cell proliferation, which results in PCOS. However, in fact, nobody has deciphered the exact cause of the disease. Approximately 50 to 70% of women with PCOS, both lean as well as obese, have some degree of insulin resistance, which probably contributes to the hyperandrogenism in PCOS. So today we are going to have a head-to-head comparison between an established insulin sensitizer, that is a metformin, versus a dietary food supplement, inositols. So let us go to the basics to understand this new kid on the block. This is an insulin signaling transduction pathway in which the insulin hormone binds to its receptor to form an insulin receptor complex which enters intracellularly and binds to the phosphatidyl inositol 3 kinase. Now this PI3 kinase combination stimulates the glucose transport 4 receptor, which in turn acts as a security guard and opens the glucose gated channels and helps in utilization of the excess glucose. Now there's a mechanism of action difference in the 2 drugs basically. Metformin stimulates the PI3 kinase, while inositols not only stimulates the PI3 kinase but also acts as a precursor in deficiency conditions. So as we have seen in the few lectures before, metformin, as per the Cochrane review, increases the pregnancy rate and ovulation rate. It shows significant decrease in the fasting insulin levels and the glucose insulin ratio, as well as the free androgen indices. It has unequivocal effects on the live birth rate, miscarriage rate, twinning, and lipid profile. However, having considered all these advantages of metformin, it comes with significant GI side effects of metallic taste, gastritis, acidosis, and very rarely but severe hepatorenal syndrome. So evidence says that metformin single-handedly fails to manage insulin resistance in PCO patients, and it inadequately treats multifactorial pathologies which are associated with insulin resistance in PCO patients. So metformin has been used since last 2 decades. But now if you're not happy with a particular alternative, it's time to think about something new. And in pursuit of thinking about what's new, this new kid on the block, inositols, came into picture. This is a comparison among currently available therapeutic treatments for PCO, which actually differentiates and compares the therapeutic target versus the side effect profiles of various drugs available for treatment of PCOS like COCs, metformin, clomiphene, myoinositol, dechiroinositol, and various combinations. What is more interesting to note that the researchers found this inositol interesting because this has absolutely no side effect profile vis-a-vis its counterparts. So as we understand, insulin is the main regulator of the blood glucose, and there are various mediators in this insulin pathway. The more important mediators being the myoinositol, which acts on central tissues or high energy tissues like the brain, ovary, and the heart, which is important for the glucose cell uptake, while the D-chiroinositol pathway is mainly active at the periphery, that is the liver, muscle, and the fat, and which is important for conversion of glucose to glycogen. So there are various sources of inositols. As we know, it's a natural dietary supplement. So it is present in dietary sources like grapefruits, beans, almonds, walnuts, sprouts, and it is not found in leafy vegetables. So what is this myoinositol? It's a isomer of 6-carbon sugar alcohol, which is important for cellular morphogenesis and cytogenesis. It is important for intracellular signaling, which is essential for the oocyte development and in vitro maturation as well. And it produces second messengers, which initiate the FSH and uptake of glucose. Now, D-chiroinositol is nothing but when myoinositol is converted to D-chiroinositol at the periphery with the help of an enzyme which is known as epimerase, it produces a isomer which is D-chiroinositol, which is important for promoting the uptake of glucose and synthesis of glycogen, and it acts as a second messenger for insulin resistance. Now, what is the basic difference which differentiates our PCO subjects from our non-PCO subjects? An interesting phenomenon is the insulin paradox, which will help us understand this phenomenon. Now, what happens is, we all know that there is an insulin resistance in obese, thin, as well as other phenotypes of PCOS. However, the insulin paradox means that the ovary or the central tissues do not have an insulin resistance, but only the peripheral tissues like the liver, muscle, and fat show this insulin resistance. So the ovary basically escapes this phenomenon of insulin resistance, and hence peripherally, because of insulin resistance, there is a decreased conversion of MI to DCI, and hence there is a peripheral D-chiroinositol deficiency in PCO subjects. And in the ovary, because it escapes this mechanism, there is increase in conversion of MI to DCI and results in a central or ovarian myoinositol deficiency. So all in all, in PCOS subjects, peripheral D-chiroinositol deficiency and a central myoinositol deficiency. So in the ovary, basically, as there is a deficiency of myoinositol, which is important for oocyte maturation, now here there is an oocyte maturation arrest, which results in anovulation and infertility per se. At the periphery, again, because of an insulin resistance and because of deficiency of D-chiroinositol, it results in metabolic symptoms because of hyperinsulinemia, like type 2 diabetes mellitus, hypertension, metabolic syndrome, while there are certain cosmetic symptoms as a result of hyperandrogenism in the form of hirsutism, acne, and male pattern alopecia. So Hemag et al. Has published in which he's found out that in PCOS versus non-PCOS women, there is a 47% decline in the peripheral DCI levels, while in the ovarian MI levels, there's a decrease up to the tune of 28%. So all in all, the missing link in PCOS management is a combination of both these inositols to tackle the central ovarian deficiency and the peripheral D-chiroinositol deficiency. So the rationale of supplementation of myoinositol in the ovary basically improves the oocyte quality, ovulation, and oocyte maturation, while peripherally, the supplementation of D-chiroinositol corrects the hyperandrogenemia and the hyperinsulinemia, thereby correcting the metabolic and cosmetic symptoms of PCOS. Now, are all inositols effective in all PCO phenotypes, especially the obese one as well as the lean ones? Let us see a few data and clinical evidence to our rescue. We'll first see the effect of inositols on lean PCO patients. Now, this is a study by Leonor et al. In which 20 patients with BMI 20 to 24 were supplemented for a period of 2 months into 2 groups. One took the placebo and the other was supplemented with 600 milligram of D-chiroinositol, and various outcomes were studied at the end of 8 weeks, which includes the blood pressure, BMI, the HOMA index, and free testosterone levels and SHBG levels. So what were the results? Now here the results at the end of 4 weeks showed that there was a decline by 73% in the level of free testosterone, while at the end of 8 weeks, the HOMA index improved by 83%. As a secondary parameters which were studied, ovulation was seen in 60% of the subjects, while there was a significant drop in the systolic and diastolic blood pressure and the plasma triglyceride concentrations. Similar results were extrapolated and seen in familial diabetic patients versus the non-familial diabetic women, and there was a significant decrease in the testosterone and the androstenedione levels in familial diabetics as well. So all in all, the UNO trial concluded that in lean PCO women, D-inositol supplementation reduces the circulating insulin levels, decreases the serum androgens, and ameliorates some metabolic abnormalities like elevated blood pressure and hypertriglyceridemia of syndrome X. So do these effects also apply to obese PCO patients? Let us see. So this is a Benelli trial which the objective was to determine the efficacy of myo and D-chiro combination on hormonal parameters and insulin sensitivity in obese PCO patients. So 46 patients were recruited which were obese, BMI more than 26 for a period of 6 months. The first group was supplemented with myo and D-inositol, while the second group was given plain folic acid for a period of 6 months. Outcomes which were studied were testosterone and androstenedione level, the BMI, glucose insulin ratio, and the HOMA indices, as well as the hormonal parameters like the FSH and LH levels. There was an effect of inositols on BMI which showed that myo-inositol decreases both insulin as well as the BMI. However, no changes were seen in patients treated with folic acid. We do understand that the volumes of these clinical trials are low, and there's definitely a more research which is warranted with better volumes. So they concluded that a statistically significant reduction in the LH, pre-testosterone, fasting insulin, and HOMA index occurred in the group which was treated with combined therapy of myo-inositol plus D-inositol. So it concluded that it is effective in restoring hyperinsulinemia and insulin resistance in young obese PCO patients as well. So now we've understood that inositols are effective in most of the phenotypes of PCOS. And now we need to know what is the optimum dosage of this myo and D-inositol if we need to supplement. Now this is an interesting study by Unfor et al. In the ovary, in the healthy condition, the myo-D-inositol ratio is around 100:1. This was done by taking ovarian biopsies and the levels were assessed. However, in PCOS condition, this ratio is deranged and it is changed from 100:1 to 0.2:1. Now, all brands which we have mostly are in the ratio of 40:1. But 40:1, as we understand, is a physiological ratio. And PCOS is not a physiological condition, it's a pathological condition. So we cannot be supplementing a physiological ratio to a pathological condition, and hence 40:1 is not a universal ratio, but it actually varies from tissue to tissue is what was the conclusion of this trial. So what is to be done? So ideal therapeutic dose of DCI is 300 to 600 milligram per day. And hence, it was concluded that rather than following a blanket ratio which is not defined, it is always better to provide for the therapeutic dose of each ingredients individually. Now, is myo-inositol safe in pregnancy? This is $1 million question which we need to address. So this is a European review for medical and pharmacological science publication which states the pleiotropic effects of combined myo and D-inositol in pregnancy, particularly in patients with metabolic syndrome and in pre-diabetic women. It concluded that MIDCI administration is useful in pregnancy, particularly in patients with metabolic syndrome as in pre-diabetics, and it has shown to significantly improve metabolic and hormonal patterns in PCO patients after 60 days of treatment, without affecting the diastolic blood pressure levels. So all these studies are available up to the second trimester, which proves that the inositols are safe in pregnancy and hence can be considered as an option in pre-diabetic women. So do we have any latest data from 2020? So this is one ASHRAE evidence which was published in Gynecological Endocrinology in 2019, which states, is there any comparative evidence of the right dose of Mayo-D-Chiro combination versus the low dose of Mayo-D-Chiro combination? So what do we mean by this? This is the trial, which is actually a multicentric trial, or the Granada, Spain trial as we all know it. It was conducted over 8 centers in 6 regions of Spain, and the main objective was comparison of effect of 2 combinations of Mayo and D-Chiro inositols in women with PCO undergoing IVF-ICSI. This is a double-blind randomized controlled trial in which first group was given a right dose of Mayo-D-Chiro, which meant Mayo-inositol 550 milligrams and D-Chiro inositol 150 milligram, which was given twice a day, and versus low dose, that is the 40:1 formulations which are available. So in this RCT, which was a double-blind multicentric RCT, 56 women were recruited in the reproductive age group with BMI less than 30, and as we discussed, the first group was supplemented with right dose for 3 months, and the second group took the 40:1 for 3 months. At the end of 3 months, all the patients were subjected to ICSI with embryo transfer, and various outcomes were studied, which included again the M2 oocyte output, the probability of ovarian hyperstimulation syndrome, and the secondary outcomes like the clinical pregnancy rate, the miscarriage rate, live birth rate, and the free androgen indices. The results showed that the right dose DCI group gave a 65.5% pregnancy rate versus 25.9% pregnancy rate in the low dose, that is the 40:1 group, while the right dose DCI gave a live birth rate of 55.2% versus 14.8% vis-a-vis in the low dose DCI group. So there were various advantages of the right dose versus the low dose DCI. It basically offers 550 milligram of Mayo and 150 milligram of DCI, so which is ideal for most of the phenotypes of PCO patients. Mayo-inositol has been used at a dose of 1 to 4 grams per day, and it offers more than 1 gram per day, which is important and effective in improving the oocyte quality, while the optimal therapeutic dose of D-Chiro inositol, which was supplemented here, was 300 milligrams per day, which has been shown to improve the insulin resistance at periphery. So this trial concluded that the right dose of DCI gave a 3 times higher pregnancy rate, 4 times higher live birth rate. There was significant improvement in the insulin sensitivity, and there was a significant decrease in the pre-androgen indices and the testosterone level. So to conclude my talk on inositols, the secret of change is to focus all your energy not on fighting the old, but on building the new. Old keys won't open new doors. So embracing the change is the only way through. And we know with so many therapeutic options available to tackle the insulin resistance in PCO patients, we definitely know the role of metformin, which has been discussed by Professor Mary Ann and various other speakers previously. But definitely this new kid on the block, inositols, may prove a point in handling hyperandrogenemia and insulin resistance. We need high volume studies again in the future to discuss this option. Thank you so much for a patient listening, and thank you to PCOS Society for this opportunity today.